important. What is golden hour? This is the first 1 hour of postnatal life. This is a critical period for stabilizing preterm and extreme low birth weight infants, for minimizing complications and improving short term and long term outcomes. What are the short term outcomes we come across at the preterm delivery? These are like hypothermia, hypoglycemia, and respiratory distress syndrome. Long term complications we expect are like bronchopulmonary dysplasia, intraventricular hemorrhage, and retinopathy of prematurity. So, why is golden hour critical for preterm? Because premature infants are physiologically immature and face unique challenges. These are like high susceptibility to hypothermia. Why? Because the preterm infant skin is very immature and loss of evaporative losses are more, and larger surface area and lack of insulating fat. These are lead to high susceptibility to hypothermia. And immature lungs and surfactant deficiency can lead to respiratory distress syndrome in short term and bronchopulmonary dysplasia as long-term complication. Fragile capillaries and increased risk of bleeding can cause intraventricular hemorrhage. And poor energy stores can cause hypoglycemia as a short-term complication, which can lead to occipital loss of vision in later life. Underdeveloped immune system can cause infections. So decision during these hours significantly impact lifelong health. So key components of golden hour management includes team approach and communication, prevention of hypothermia, effective and gentle resuscitation, delayed cord clamping, optimal respiratory support, nutritional and fluid support, prevent iatrogenesis and sepsis, and family communication. So team approach includes multidisciplinary team should be ready with 3 to 4 members, one senior neonatologist, neonatal fellow, 1 or 2 pediatricians with nurse, who should be ready for resuscitation, and each team member should know their responsibilities prior to the delivery of the preterm baby, and they should use checklist for equipment, and standardized protocols should be followed as unit protocols. And they should have there will be coordination with the obstetric team and before and during delivery, and the parental counseling is more important. What the parental counseling includes? Parental counseling includes gestational age of the baby, approximate weight, and what is the survival chances, and what are the short term and long term complications they will come across. So prevention of hypothermia is more important. This should be get ready before the delivery of the preterm baby. So we have to set the delivery room temperature at 25 to 27 degrees centigrade and higher if needed for less than 32 weeks of delivery babies. And use a pre-warm radiant warmer, and ensure it should be switched on just 10 minutes before delivery and with 100% heater output. Utilize the plastic bags or wraps we can use, and immediately after delivery of the preterm baby, we have to keep the baby in plastic bags without drying the baby, because to reduce the evaporative heat losses. And thermal mattresses on caps we can use to prevent the to provide additional warmth for extremely preterm babies. And use transport incubators and transfer the baby from delivery room to NICU with transport incubator. So delayed cord clamping is more important thing. WHO, ACOG, AAP, and all IAP all are nowadays encouraging for delayed cord clamping. Why? Because delayed cord clamping has so many benefits, like 30% reduction in hospital mortality, improved blood volume, better hemodynamic stability, improved stem cell and immunoglobulin transfer, reduces the risk of intraventricular hemorrhages and necrotizing enterocolitis, increases the iron stores, and that decrease the need for transfusion. So anemia risk is less in premature infants, and benefiting the brain development in first few months of life. Only one disadvantage with delayed cord clamping is jaundice, which can be treated with phototherapy. So we have to consider delayed cord clamping in stable babies. In unstable babies, means baby is not cried, requires resuscitation, then we have to we should not do delayed cord clamping. We have to cut the clamp immediately, and please hand over the baby to neonatologist for further management. And shall we do cord milking in these babies? No, we don't encourage cord milking because of the risk of intraventricular hemorrhage. So after delivery of the baby, if baby is crying and no need of resuscitation, we have to keep the baby supine, and shoulder roll and positioning is more important, and we can dry the baby if more than 32 weeks. and baby should be, if required, we have to start CPAP, or if baby is not cried and baby requires resuscitation, means we have to start resuscitation with TP's resuscitator, because it provides controlled tidal volumes for preterm babies. Avoid high airway pressures. The pressure should be with PEEP of 6 to 8 centimeters of water and PEEP of 20 to 25 centimeters of water. According to that, we have to adjust, depending on the saturations and work of breathing, we have to adjust the pressures, and this one. Target saturations are important. Target oxygen saturations are delivered using the blender. We have to use blender for FiO2s of required FiO2. That is, for less than 28 weeks baby, we have to give 30% oxygen, and 28 to 31 weeks we can give up to 21% to 30%, and more than 32 weeks we can give we can resuscitate with room air. And if FiO2, the target saturation should be 80% by 5 minutes of age. So if baby cried immediately after birth or not cried, required resuscitation. After that, we have to assess for the work of breathing and retractions by Silverman-Anderson score. If the score is more than 4, baby needs CPAP support. So initiation of delivery room CPAP is now we are encouraging for delivery room CPAP for those babies. And the early rescue surfactant also we are giving and administering surfactant within first 2 hours of life if needed. If FiO2 requirement is more than 30%, work of breathing is more, and X-ray ultrasound suggestive of respiratory distress syndrome features, then we have to give early rescue surfactant. And if baby is not cried, required ventilation, and we have to give gentle ventilation strategies we have to follow, like utilization of volume guarantee modes, and we can minimize lung injury by using the volume guarantee or volume target ventilatory strategies. Hyperoxia should be avoided, because hyperoxia can cause retinopathy of prematurity. So we have to target the saturations between 90 to 94%, and alarm limit should be from 89 to 95%. And nowadays we are starting caffeine for all babies who born less than 32 weeks of gestation for prevention of apnea of prematurity. And along with that, all these measures, in first hour only we have to start nutritional and fluid support for all preterm babies, because they lack stores. That's why we have to start intravenous fluids like dextrose, lipids, protein, and within the first 1 hour of life. For these are high osmolality fluids, so we have to insert umbilical venous catheters. If needed, umbilical artery catheterization also we have to do if regular ABGs are necessary. Consider early enteral feeding. If the baby is stable, not requiring, means no contraindication for feeding, then we have to start minimal enteral nutrition. This we start 10 to 20 ml per kg per day. And maintain normoglycemia is more important, and regular glucose monitoring we have to do. Prevention of iatrogenesis and sepsis by use of aseptic techniques like apply strict hand hygiene and sterile procedures to prevent the infection is more important. And we have to avoid rapid boluses for the prevention of intraventricular hemorrhage, and also for hemodynamically significant PDA risk is more if we give more rapid fluid boluses in these babies. And antibiotics should be started empirically if infant is at risk for early onset sepsis, and we have to send blood culture. After that we'll start antibiotics. And if the cultures are negative and baby is clinically stable after 48 hours, we can stop the antibiotics. So physical injury can be minimized by gently handling the baby, and gentle handling and positioning, and by developmentally supportive care include noise reduction, gentle handling, coupling procedures, and skin care, and early parental participation, that is by kangaroo care. So monitoring of blood pressures, aim for normal tissue perfusion, and start inotropes if necessary. We can do functional echocardiography bedside, and according to that we can start inotropes. And maintaining hemoglobin within acceptable levels is also more important. And manage jaundice with phototherapy or exchange transfusion if it is in pathological ranges. So, family communication is more important. Providing information and engage with parents before and after delivery is more crucial, and keep them informed. Discuss the baby's condition, procedures, and treatment plan. Timely interventions and all are helpful. Create a trusting environment. Allow families to see and touch their babies as soon as possible if the baby got stabilized. So golden hour checklist include pre-delivery, team should be assembled, radiant warmer should be ready, polythene wrap or cap and all the things for thermoregulation should be ready, and immediate post-birth, infant should be placed on warmer or transport incubator, and initial heart rate breathing should be assessed, and delayed cart clamping if stable. If baby is not stable, then we have to do early cart clamping. And respiratory support is initiated, that is delivery room CPAP. Preductal saturations should be monitored and IV access should be secured. If necessary, baby is transferred to NICU, means in incubator, we have to transport the baby to NICU under thermoneutral environment, and continuous monitoring during transport is mandatory. So this diagram depicts the golden hour management of the baby, like what we have to do: antenatal counseling and team briefing, and send required laboratory investigations after delivery, prevention of hypothermia, communication with parents, nutritional care, nosocomial infection prevention, and keep necessary records like auxiliary temperatures and resuscitation details. Cardiovascular system support, and give support to respiratory system by delivery room CPAP or NIV or HFNC, or required volume targeted ventilation or high frequency ventilations. Nowadays we are going towards the high frequency ventilation for extreme preterm babies, if because it delivers low target volumes, and it prevents the lung injury. So we are encouraging high frequency ventilation for preterm babies. So therapeutic hypothermia. This therapeutic hypothermia is indicated in term babies who were born with birth asphyxia with moderate to severe hypoxic ischemic encephalopathy. If we start therapeutic hypothermia within 6 hours of life, and if it is continued for 72 hours, the mortality and the risk of cerebral palsy will be decreased. So we encourage therapeutic hypothermia for moderate to severe birth asphyxia babies. So as a doctors, we are trying to act to assess and diagnose, but we have to take some pause. For what? We have to listen some voice. What is that voice? The voice of the baby. If baby can speak, baby may deliver, maybe say these words: if I am going to be born preterm and small, please give my mom steroids and help me survive. Don't allow me to contaminate amniotic pool with my meconium. If so, take me out at earliest and help me survive. During labor, I am traveling through narrowest passage in my life. So I may be in trouble. Please be there fully armed to help me in case if I need it. Despite your help, if I am in trouble, help me to transport to the nearest good center. So they cannot speak. If speak, the baby may say these words to us. So please transport the baby by transport incubator along with the neonatologist team if necessary, or if possible, transfer the baby in utero where the NICU facilities are there. That will be helpful for babies' long-term and short-term complications to overcome. So sometimes the most powerful guidance does not come from textbooks or machines, but from imagining the voice of the baby asking us for the chance of life like this. Okay. Take home summary and take home message is: the golden hour is a critical evidence-based strategy for managing preterm infants. It requires a coordinated team, clear protocols, and attention to key interventions like thermoregulation, respiratory support, and nutrition. Successful implementation relies on your communication, teamwork, and adherence to best practices. Effective golden hour care can significantly improve outcomes and give high-risk neonates the best possible start. Because of, as neonatologists and obstetricians are caregivers, we hold the power to change outcomes, not with miracles, but with timely evidence-based care, that is golden hour management. Thank you.